Hello, everyone. My name is Supriya Medapati, and I lead product and growth at Cure.ai. And I'm focused on essentially finding innovative solutions in ways we can add value and make healthcare accessible and affordable to everyone across the globe. So today we have Dr. Jeyaraj Pandian with us. And Dr. Jeyaraj Pandian is Principal and Professor of Neurology at CMC Ludhiana. He's also the Vice President of World Stroke Organization, which is a non-profit medical association that works to raise awareness of prevention and treatment of stroke. He has over 30 years of experience and has done much needed research about stroke care in low and middle income countries. He has many national and international publications and has won several awards and memberships to his name. So, Dr. Pandian, welcome, and we are very humbled to be in your presence.
Thank you, Supriya, and it's my privilege.
Thank you. So, Dr. Pandian, why don't you tell us and the audience a little bit about yourself and your day-to-day work?
Yeah, so my area of expertise is neurology, and in the field of neurology, it's stroke. So I did my stroke fellowship from Australia, and then came back to India in the year 2007, and upgraded the stroke program that was there in CMC Ludhiana, and also the research, the network, and so basically I'm primarily involved in stroke. Plus, for the last 3 years, I've been with the medical college as a principal and dean at CMC Ludhiana.
Great. So I think right now, COVID is dominating every conversation. I don't think we can have a conversation and not talk about COVID. So from your perspective, what do you think has been the impact of the pandemic on critical care for neurological disorders like stroke as well as others?
Yeah, so the pandemic, when we had this lockdown last year, somewhere the end of March and April, beginning of April, there was a dramatic reduction in the number of stroke patients reaching the hospitals. Not only stroke patients, people with neurological problems. However, that was a transient period, I would say, for 2-3 months, and then slowly, the emergencies came, and the patients started coming to the hospital. But the response was different. They used to come to the hospital and get the diagnosis of stroke, but they won't get admitted. Nor they were willing to get this clot-busting drug, the injection, or mechanical thrombectomy, to remove the clot. And so that was a major challenge. And slowly things improved, and maybe even at the peak of pandemic in September, October last year, August to October, patients were still coming, but with less numbers. And then slowly it improved from January, February, and then we have the second wave. There is again, now currently, we have a significant reduction in number of neurological patients, as well as stroke patients who come to the hospital.
Okay. And I think it also talks about the awareness people have about stroke, right? And how important it is to, get to the hospital in time and get the required treatment in a timely manner. So I think it's also awareness is also the first step to treatment. So what do you think is the current levels of awareness in the general public about stroke, as well as the importance of getting timely care and how to identify stroke early on?
Yeah, the awareness of stroke among Indian public is, I would say, is rather not very low, but people are aware, that what is stroke, and people try to equate stroke with heart attack. And over the years, through World Stroke Organization and Indian Stroke Association, many of our members and stroke neurologists, we have created awareness of stroke among the general public in whatever capacity that we have been doing it, and through mass campaigns, particularly there is always a build-up of stroke awareness activities before the World Stroke Day, that is October 29th every year. And every year we have this theme also before the World Stroke Day. And so awareness is improving. And for example, if I speak for Ludhiana city, when we started the stroke thrombolysis program way back in 2001, and now if we compare, people are aware, if they reach a hospital in time, they will ask for this particular injection that has to be given.
Right.
And but the awareness about mechanical thrombectomy is, it's not there, and we find it very difficult to get concerned for mechanical thrombectomy, and because it's very expensive as compared to thrombolysis. Thrombolysis also is expensive, but at least affordable. But mechanical thrombectomy is about 10 times the cost of thrombolysis, and so it is improving, but we have a long way to go. We are working on it with Indian government and also as NGO, Indian Stroke Association, and also World Stroke Organization. Even World Health Organization has been involved now. Last year we had a joint forum with World Health Organization for 11 Southeast Asian countries on stroke and awareness.
That's really amazing. I think with all the global organizations coming together, hopefully things will get even better in the coming future. So I think one of the things that I wanted to highlight is comparatively in high-income countries or some of the Western world like US or UK, the developed countries, they've been able to bring stroke care under control or pretty much be able to manage stroke care a lot more effectively, right? So I wanted to understand from your perspective, what do you think they've done differently or better? I mean, obviously they have higher resources, but at the same time, what are those best practices which you think we can take from the Western world? And at the same time, what do you think is relatively different that we have to do because of different challenges that we have in low and middle income countries?
Yeah, the most important thing with the developed countries is the healthcare system. If you look at the healthcare system, if you compare it with stroke care, how it has to be organized, like it starts with pre-hospital care, then the emergency department evaluation of patients, then the imaging, then managing them in the stroke unit, and prevention, secondary prevention strategies, discharge plan, rehabilitation, community care. So all these the components of continuum of care are integrated. For example, if somebody has a stroke symptom, they have to dial the emergency number. It varies from country to country. And immediately the ambulance is dispatched and they come with that reasonable time period, and then quickly evaluate these patients, take them to the emergency department where they are rapidly triaged. The stroke code is activated, and quick evaluation and imaging, and thrombolysis is available free of cost or insurance pays, or if the patient is eligible for mechanical thrombectomy, and, the typical stroke hub and spoke model. If they don't have mechanical thrombectomy, they refer these patients to comprehensive stroke center. So it is the infrastructure and the systems of care and also the expertise. Of course, they also have human resources issues, but at least the systems of care are there. So this is for the stroke care pathway. But if you look at the burden of stroke, there is a reduction in the incidence of stroke and also the mortality of stroke. On the other hand, the prevalence of stroke has increased in developed countries. The reason is because there is a very good integrated healthcare system. For example, a stroke patient is managed in the stroke unit and they have a discharge plan, and it is all clearly defined. And the general practitioner, the patient is referred from the comprehensive stroke center to the general practitioner. And the general practitioner takes care of the control of blood pressure, diabetes, cholesterol, and the patient is on antiplatelet drugs. And if they are on oral anticoagulation for atrial fibrillation, that is monitored well, so that another stroke is prevented. And in addition to examining these patients for respiratory tract infection, they measure the BP and they'll check whether they have any diabetes or cholesterol yearly. The citizen can go and do their annual checkup. So screening is done at a population level. So they pick up these patients with hypertension, diabetes, high cholesterol at a very early stage, and implement prevention strategies. So in that way, there is a reduction of stroke in the population. So the health system is integrated to manage stroke patients when they come into the hospital. And number two, the secondary prevention, that link is established, and also the primary prevention is going on not only for hypertension but for all the other vascular risk factors. So that is the major drawback with LMIC, where it is all fragmented. Sorry.
Yeah, I think that makes complete sense. So I think one other thing that hopefully can make a difference in LMICs is interventions with technology, right? And I think with artificial intelligence as well as various technological advances, the whole stroke workflow can be a lot more streamlined. So I wanted to get your thoughts on, what you think technology can do for the stroke workflow and improve stroke care in LMIs.
Yeah, technology definitely, can improve many components of the stroke continuum of care, even from early recognition. You can use technology. For example, the ambulance crew is in the house, and if he has an algorithm, okay, this patient has facial weakness, patient has arm weakness, if they can enter in an app and you have an AA algorithm, this is probably most likely a stroke patient, and immediately they can shift these patients. And when they arrive in the emergency, of course, we can have the algorithm of doing the NIHS, the stroke severity, quick examination, and finally is the imaging. That is very, very important, where you can the interrated variability can be reduced. Sorry. If there is an AI algorithm, and that is where I would say, in terms of stroke, diagnosis and management, AA has a major role, particularly the early detection of ischemic stroke and hemorrhagic stroke. And also, there is evolving technology in trying to pick up the ideal patient for intravenous thrombolysis and also mechanical thrombectomy. I'm sure in the next 2 years, we'll be having many applications where which would become cost effective or low cost, so that in LMICs we can have affordable AA technology by which we can improve the diagnosis of stroke, management of stroke, and also the workflow. So currently, for example, if I want to document the door to needle time, it is all manual. So somebody has to, the nurse would have entered the time of arrival. You go back to the record. We don't know whether the nurse accurately entered or not. Then you go to the imaging. When did the imaging begin? So the door to CT time. So in an AI-based stroke workflow, all this can be automatically generated as soon as the patient comes in. And there is a big scope for, I would say, we still struggle with which patient will improve in stroke, because stroke is so heterogeneous. Every stroke patient is different. And of course, we have guidelines. Of course, we have criteria to select the right patient for thrombolysis and mechanical thrombectomy. But still, a lot we need to improve on that. And particularly predicting recovery and rehabilitation. Who's the right patient for stroke rehabilitation? We still don't know. No, as we have some evidence, but that is where I would say, there is a major role of AI, not only in diagnosis and management, but also for prediction of recovery.
Absolutely. I think, thank you so much, Dr. Pandian. That's been really insightful. So I think even at Cure, we are trying to solve this problem. So I wanted to ask you, because you've been working on stroke care and trying to improve this for a very long time now. So what motivates you to, what motivated you to get into this field and stay in this field for such a long time? And, what are your reasons behind stroke advocacy?
Yeah, so I can share a few patient-related stories. Now, what really motivated me, and I was trained. I did my neurology training from CMC Institute, Trivandrum, completed in 1999, and that center is even now known as one of the best epilepsy centers in the world, and also the best movement disorder centers in the world. And so when I came back to CMC Ludhiana in the year 2000, so I developed epilepsy at CMC Ludhiana. I within a span of 3 years, I was known internationally. I established, along with my teacher back in Sri Chitra, pregnancy and epilepsy registry in Ludhiana, and also established the epilepsy surgery program. But what I found was that was not the major need in this region. Mm-hmm. And simultaneously, I was doing a lot of stroke research. I started the stroke thrombolysis, even though my area of interest was epilepsy. But I started stroke thrombolysis, and so once I remember one young lady, middle-aged, probably 40 years, she had a stroke and she came and very late, and she had a major ischemic stroke and she became bedbound. And her daughter, she was 20 years, I think, if I'm correct, and she was in the college, first year of the college. And she became the caregiver. She had to discontinue the studies and she had to take care of the mother. And that was the impact, we could see on the family. So this is just one example, but there are many stroke patients in LMICs, where it affects the family, and either they go into poverty or someone has to take over as a caregiver because we don't have a support system for all these patients. Okay. So this really, motivated me that what we need is further training in stroke. So then I had the opportunity to go to Australia and get trained and come back, and then I had a clear vision when I came back. I wanted to improve stroke care. I wanted to come up with proper incidence data for our country, models of stroke prevalence, and also wanted to develop a stroke clinical trial network in our country so that we can answer our own problems. For most of the evidence-based treatment, we look upon the Western countries. And but for India, such a huge population that we have, we need to have our own stroke clinical trial network. And by God's grace, I was able to achieve most of the things. And so this is what I would say, which really motivated, the need. I saw the need around me, and it was a 360-degree turn from epilepsy to stroke. Right. And even now, many of the epilepsy specialists used to ask me, I know you left epilepsy and you went to stroke. And so these are some of the motivating factors which really helped me to take a call on which area to focus.
That's amazing. Thank you so much, Dr. Pandian. I think your journey is very inspiring to pretty much everyone who's listening as well as us. So one thing for our audience sake, right? Would you be able to walk us through what happens in an emergency room when someone with stroke comes in, right? Especially in LMICs. And also, obviously that process, like you said, is broken and fragmented because of various reasons. So what would be your suggestions or guidance to the medical community on, some of these areas which are broken? How can we improve and how can we work around the challenges that we have?
Yeah. So if you look at the stroke continuum of care for LMICs, pre-hospital care, I have done multiple things to improve that. We even had our own the ambulance services for stroke and emergency accident and emergency, a mobile ambulance service in CMC. Uh, I can say that over the years, only one patient had called our ambulance service and came to the hospital within that time period and received TPA. Uh, as part of the Punjab State program, stroke program, I have I was involved in training the ambulance crew 108. But even in our Ludhiana population-based stroke registry, we have trained the ambulance crew and the ASHAs to identify stroke patients in the villages. But a very small proportion of them have used 108 and they come to the hospital. More than half of them come using their personal car or any hired vehicle and they reach the hospital. For LMICs, the most important thing is reach the hospital either by ambulance or using their own conveyor. So that is the best way to follow so that they don't waste time. Because dispatching an ambulance, the ambulance can be stuck in traffic, or while returning also the ambulance can be stuck in traffic. So it is better they reach the hospital by their own conveyance as quick as possible. Then second is in emergency department, you need to create awareness. You need to train the people there, the doctors, nurses, about rapid evaluation and create a stroke code or some system where these patients are identified quickly and you screen them quickly and take them to the imaging. So the emergency department is very, very important. Then the radiology department, you need to talk to them, sit with them, and tell them, if a stroke patient comes, you need to remove the patient who's in the scanner, whether it's a CT or an MRI. The other patient, you need to remove them and then put in the stroke patient. So that is importance you need to give in the radiology department. Then the quick evaluation, interpretation of the scan, and you should not be waiting for the radiologist to report. If you have a very good radiologist in your team, that is well and good, but it is after 5 o'clock and you should not be waiting. The main purpose is to exclude hemorrhage and try to see whether there is an established big infarct or not. So you'll be able to pick up the right patient. And of late, many centers in LMICs are giving TPA even in the CT scan without wasting time. And if you have a facility for mechanical thrombectomy, alert the cath lab crew, the staff, so that they come on time and keep the cath lab ready and take the consent and start the procedure to every patient who is discharged, including at the time of discharge, the discharge plan. You need to have a checklist where this patient, whether patient is on antiplatelet drug, antihypertensive drug, anti-diabetes drug, or oral anticoagulation. So, and a proper diet plan. So if you do all this, the patient care improves and the number of patients who receive thrombolysis and mechanical thrombectomy will improve.
Great, absolutely. It's been an amazing time talking to you, Dr. Pandian. I think we've known each other for some time, but it's been a great pleasure talking to you about stroke care and LMICs and sharing this information with our audience here. So thank you so much for your time. Do you have any parting words for us as well as our audience?
Yeah, I think my final comment would be, stroke is an emergency and we should not waste time. And rapid evaluation of these patients is very crucial. Rapid recognition and evaluation and referral. That is where we have major problem in our country. A proper networking, hub and spoke model, and a referral system needs to be created. And the stroke systems of care within the hospital needs to be improved and strengthened, and so that these patients are taken care of properly. Thank you. Thank you very much.
Thank you so much, Dr. Pandian. Have a good day.
Yeah, thank you. Bye.